Thank you very much, everyone, for coming to our Innovative Discovery series. We are really thrilled today to have one of our own, Vishal Patel, to talk about strategies in the treatment of diabetes. But before I introduce our speaker, let me go over some housekeeping issues. So as you know, for CME credit, you must sign in and you must include your email and credentials. Don't miss our September 6th Tech Talk, so you have a long time to put it on your calendar. And we'll have a statistician from University of Delaware, week 1, to come and give us a talk. Also, please note that the June 22nd ID series, so next week, we'll have a special guest, Dr. Michelle Kutzler from Drexel University, speaking on changing epidemiology of Clostridium difficile infections, making a case for preventive and therapeutic vaccines. So please register to help us prepare. And as usual, the full schedule is posted on our website, DE-CTR.org. So I'm really happy to introduce Dr. Patel here. Dr. Patel is a senior physician investigator at Krishna Care Value Institute and also directs clinical quality, safety science, and innovation research projects for the primary care and community medicine service line. More specifically, he has a strong interest in digital consumerism, focusing on the ideation and evaluation of new models of ambulatory care delivery. He graduated from the Leadership in Medicine program from Union Graduate College in Schenectady, New York, and Albany Medical College, and this program combines undergraduate studies in chemistry and economics, an MBA, and a medical degree. He did his residency in MedPeds here at Christiana Care, where he also became chief resident, and prior to coming to Christiana, he worked at MedStar Health in Washington, D.C. as an urgent care physician, and also led several quality and safety initiatives. He was also a pediatric hospitalist at the Children's National Medical Center in Washington, as well as assistant professor of pediatrics at George Washington University Medical Center. So welcome, and we are very excited about hearing about Rethinking the Consumer's Diabetic Journey. That's a great title.
Thank you very much. Mentioned, I'm a peds provider, do primary care here at Christiana Care, and have the pleasure to work with many of you guys at the Value Institute. Also happy that some of the staff and the medical assistants and clinical staff that I work with at MAP2 are also able to join, so I'll call on you ladies during some of this talk as well too. So just some housekeeping, no relevant financial disclosures, and this is just some of the key objectives. So being that I'm in primary care, I like to keep things very simple. So, the first few slides and information is just going to be more of a broad overview of the obesity epidemic, how it pertains to not only our nation, but then more specifically to Delaware and the neighbors that we serve. Then talk a little bit about what the current state of how we're rendering care for many of these patients, both in the walls of our offices and then while they're not with us, and then touch on some newer models of care. Some of these are more digital virtual, and some of these are models that have already been in existence for almost over a century, and how we can utilize some of these learnings and apply it to some of the patients. So before we start, I know Dina had sent out the invite that there was going to be free lunch, and I also use that as a ploy to get some of you guys here. But the first lesson is there's no free lunch. So before we begin, I just want everyone to stand up, and we're going to do 10 jumping jacks before we begin today's talk. So you may see a theme of this during this presentation. Just so that you guys don't hurt the people next to you, you can just put your hands up. Hopefully, this is the first time I'm wearing this suit, so hopefully I don't break anything. Whenever you guys are ready, we'll start. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Did anyone catch that on Snapchat or Instagram?
Crispy with the fried fish on.
So the first few slides is just going to be giving a more of an overview background, and many of you guys already know this, and I can show you guys multiple slides on this. So we know that there's an obesity epidemic. Unfortunately, or fortunately, however you like to put ourselves, we're leading the way. In some areas, leading the way is a good thing. However, this, as you can see at the bottom, almost 40% on this study, and this was from 2016, over almost 40% are either overweight or obese. And a little joke on the side, maybe this is a reason why the USA is not playing in this year's World Cup. Ironically, yesterday when I was looking at this slide and I was watching a little of the World Cup, I saw that if you look at the top 10 countries, 7 out of those 10 are in this year's World Cup. And then if you look at the bottom 10, I think only 2 or 3 are in the World Cup. So again, probably just a association, and because there's multiple reasons why teams are playing in the World Cup. But either way, we see that we're almost double the average for industrialized countries. So then now talking a little bit more about Delaware. So we know that this is a national epidemic, but we also know that this is a problem here in the state and the patients that we serve. So almost 30% obesity rate. We're sort of below the pack or below the average for the country, and these stats are from 2016. Just another graphical description. So from 1990 to 2016, the rates of obesity has doubled from 15% to over 30%. So as you can see, we're starting to see an exponential rise. So it was sort of flat here, and we're starting to see an increase. And look right here, and if we sort of project out, we see that rate is going to continue to rise. So the first slide was more about adults, and now we're starting to realize that this is not only impacting our adults, but a lot of this is starting at a younger age. So if we're looking at, this is 2 to 4-year-olds, so WIC is women, infant, and children. So this, many of the children here are from lower socioeconomic families, and as you look at the obesity rates, we're ranked 3rd. Once again, this is something that we don't want to be highly ranked. So we're one of the worst states in terms of childhood obesity. And as you can see, the rates have sort of flattened, but if we're already starting at 15%, sort of that benchmark is already at 15%, whereas other countries may be under 5%. So we know that if some of these children are at a young age, have issues with obesity and weight issues, that this is going to continue throughout their lifetime. And as a pediatrician, and now for almost 2 years being a father, it's sort of scary to see that a lot of this, and more literature is saying a lot of this is starting at a younger age. And before it used to be primarily an adult disease, but now we're starting to see it even in pediatrics in terms of obesity. So then, obviously I talked a little bit about obesity, but how does that sort of tie to diabetes? And for the purposes of level setting, and I'm going to use the word diabetes and primarily referring to type 2 diabetes. So type 2 diabetes, which used to be more adult onset, now we're starting to see it in kids. It's primarily related to insulin resistance, and whereas type 1 diabetes is diabetes that we typically see in individuals when they're born or younger in age, and that's more due to them not having insulin. So for the purposes of this talk, a lot of this is around type 2 diabetes, which is well over 95% of the individuals, and it's very closely linked to weight. And as we saw in the previous slides, the rates of obesity have been increasing over the last 16 years, and we look at that, or over the last 25 years, and if we look at that, sort of the diabetes curve sort of mirrors very similarly the previous curve around obesity. So our current diabetes rate's around 10%, and if we look at the state, we have a little under, or 10.6, we have about 900,000 plus individuals in the state of Delaware, so that there's about 80,000 cases, and then if we sort of project out and look start moving forward, about in the next 10, 12 years, the number of patients that have diabetes in our state is going to be well over 120,000. Obviously, other chronic conditions that sort of follow suit in terms of the obesity epidemic, we're starting to see increases in heart disease and obesity-related cancers. You can obviously see that heart disease, the projected rates are exponentially higher than some of the others, and that's because there are other factors such as smoking, and then now that individuals are living longer or projected to live longer, we're going to see more individuals with heart disease. So now moving towards the patients that we serve. So this is, I'm going to share a few slides on some of the work that we've done at the Value Institute in terms of looking at those individuals that Christiana Care takes care of in terms of primary care. So these are individuals that we've seen over the last few years, and roughly 16,000 patients, and some of this data is from our current EHR, and we were able to sort of pull some from claims and other sources. So about 16,000 patients, and the fortunate thing is that we're able to understand more about these patients in terms of demographics, in terms of some of the social determinants of health, and understand sort of where they're coming from, and then this may help us identify potential interventions. So in terms of the individuals, this is just a snapshot of one of the data elements and metrics that we're able to pull in terms of where they're coming from, gender, and Maddie that's here has also done some of this work looking at where they live in the state and then compare that to where our practices are. So there's a lot of sophisticated work that can be done in terms of really identifying where these individuals are. And then hopefully with some of the work that Claudine, myself, one of our students from University of Delaware, will be able to do with this is also look at when they're diagnosed and potentially other complications related to diabetes as we sort of map forward. So we'll be able to get even a more richer understanding, and this will ultimately help us identify where there are potential gaps, and then also when we're providing education to our patients, many of us in the audience here interact with patients, we'll be able to provide them with more information rather than you're going to be able to get heart disease, you're going to have cancer, whatever it may be, but hopefully provide more individualized education back to the patient. So what does this all mean? I mean, I shared, obviously, the stats are pretty staggering. We know that the population of diabetics is continuing to grow. We know as an institution, we're in the process of expanding our primary care with the hopes of doubling our presence in Newcastle County. So if we looked at that and looked at where our current data is and sort of future projections from the previous slides, that's equivalent to the next few years, we're going to be taking care of 30,000 diabetics, and then by 2030, with that sort of 1/3 or 30% increase between now and 2030, that's going to be 40,000 patients. And obviously the rates of heart disease, obesity-related cancers are also going to follow suit and be a lot higher. So before I think, we talked a lot about diabetes, and that's after individuals may be diagnosed, and we also have to recognize that we have an opportunity prior to them being diagnosed with diabetes in terms of pre-diabetes. So the same thing, there's obesity, there may be overweight, and we know that almost 1/3 of our country has pre-diabetes, which is pretty staggering what those stats are, and that 9 out of 10 of these individuals may not even know they have pre-diabetes. So many of us here that work at the organization know that every year, every 2 years, you may do a biometric screen, and one of the blood tests that they're checking is your hemoglobin A1C. That's a blood test that looks at your average blood sugar over the course of the previous 3 months, and based on what that value is, you could either be in no diabetes, pre-diabetes, or diabetes, and that's just one diagnostic test to diagnose, and we're fortunate that we get that tested. However, approximately 90% of the individuals may not even know they have pre-diabetes because they may not have symptoms, or they may not be getting tested. Fortunately, we know that individuals that have prediabetes, there have been various different programs that have been published that have shown that if they eat healthy and they're more active, that their risk of developing diabetes is cut in half. And that's a testament to what most of us in the room here do, because we're frontline talking to patients to really counsel them about eating and being more active. And we're doing the best we can. However, even with all of the work that we're doing, we're starting to see increases in our obesity rates and our diabetes rates. So recognize that I think we're making a valiant effort. However, we may have to sort of pivot or sort of augment what we do with team-based care, doing things virtually, digitally, and also providing things in a different format and really meeting patients where they are so that they're getting the appropriate education so that, we're not going to have a third of our country that have prediabetes or, taking care of 40,000 individuals that have that. So before we move forward, I know there was those handouts that so it's essentially from a website that says, do I have prediabetes? As you can see from that list, there's various questions. Some of them are modifiable risk factors, and some of them aren't. Obviously, your age, gender, potentially family history, that's going to be a yes or no. However, as you could tell from that document, you can get up to 2 points based on what your weight is. So your weight has a very strong influence predictor of potentially developing prediabetes, and that's something that we can help influence through healthy eating and being more active. So I think it's just good to know, good to have. It's something that you can share with your patients. It's a very quick test, and it may be something that can be tracked over time. And if you notice that their risk goes down or the risk goes up, it may adjust how you're rendering care. So to sort of shift gears a little bit, and now that we sort of understand that there is this epidemic, we know that this is something that our nation is something that our nation is suffering from, and then it's something that impacts the patients that we serve here in Delaware. To talk about sort of the concept of consumerism, talking about sort of how we're rendering care. So I'm in the process of buying a new car. So yesterday I was on a few different websites, and you can sort of build your own car, right? So you're able to go in, pick the color of the seat, maybe the type of engine, so that you can sort of go through this and pick a lot of these different elements and then they can build a car, and you could sort of virtually see how your car may look like. But if we had to, fortunately I was able to just go to one website, so I was able to, either go to Toyota's website, Honda, whatever company I want, I would just go to their website. I don't have to go to 8 different websites to sort of find the engine at one place, the body somewhere else, the tires. But what if this is how you have to buy a car? You have to go to all these different websites and look at all these different vendors, and each of them have different billing systems. So if I were purchasing a car, and if that's how this is pretty much how the car would look like, right? So obviously that's not something that's appealing. That's not something that you can drive, but it's pretty much how you put all the parts together. And it was up to me to sort of assemble those parts. And I had to pay each of the vendors because I purchased the tires from one place, I purchased the seat from somewhere else, and maybe some of the internal things from another company. So I assembled all the parts. I had to pay each of the vendors. The car may work, may not work. I'm paying full price. So it's pretty easy to tell. I know this is a made-up example, and it's not sort of really how it's done, but just to sort of prove a point, the average customer really wouldn't do this. But unfortunately, this is how things are within healthcare. So we all know that, healthcare is rather complex. The product we're trying to purchase is sort of our physical well-being. And we're responsible to sort of assemble that health. And we oftentimes have to deal with sort of multiple providers, care team members, and, in the example in the state here, and a lot of places within our country, that may be different individuals that may not communicate, different electronic record systems, different payment systems. You have to oftentimes make some decisions about how you're going to get that care. And at the end of the day, similar to the example I demonstrated, you're paying full price if it works or doesn't work. So, you're going to be paying for it even if your weight goes up, even if your diabetes gets worse, whatever that case may be. And then now, how is this relevant to some of the work that I'm doing, seeing patients on a day-to-day basis? So from a provider standpoint, we know that providers are backlogged in terms of appointments. They're shorter appointments. This is leading to decreased time in terms of some of the communication. Our patients are dissatisfied because of longer wait times, the shorter appointment lengths, and then there's this whole epidemic of provider burnout leading to increased stress, leaving the workforce. And as many of you guys have seen locally, there's been sort of a decrease in primary care, more from a burnout and various other sort of political reasons. So this is something that is near and dear to all of us that's in the room that impacts the patients that we serve. So what I tried to do, and I'm going to have some of my staff and some of the medical assistants I work with in the back also sort of chime in just to get a sense of what current state is in terms of some of the patients that we see. So what I did was I looked at the patients that I saw over the last 2 weeks. And I surveyed about 100 of the patients that I saw, and this was sort of retrospectively. So after I saw them, I sort of went back, and I did this a few days ago, in preparation for the slides here. And I looked at 100 adult patients just for keep it a little bit more simplified. And 73 of them were either overweight or obese based on their BMI. And fortunately, with our current EHR, when the weight and the height is placed, and correct me if I'm wrong, overweight or obese becomes one of the problems, and it fires a task for the care team members to provide some documentation, a handout to the patient. Is that correct, Tosh? Yeah. So per day, this was 73 out of 100, but is that in line with what you see, like when you're rooming patients, how often you're printing out? Yeah. So that's current state. So you print out a handout, and obviously there are multiple things that you're doing while you're rooming the patient. So when you give the handout, is there any sort of dialogue, communication you have, or is it really just hand and then move on to something else? I'm not trying to pick on you right now. Yep. So we know the vast majority of the patients are overweight and obese, and that, and even some of the, every year our institution, through biometric, also captures this for the employees here, and this is sort of in line in terms of similar rates to the employees of the institution. Then the next thing I did is there is an operational tool that our electronic record has that sort of captures how long I'm spending per patient from a documentation standpoint. So over the last 2 weeks, it came out to, and it may not be the most perfect system, but it came out to about 18 minutes per patient. And then I was reflecting back on, when I'm seeing individuals, when I see that, like, what do I say? And I have sort of a generic sort of messaging that I do in terms of, I tell individuals, I try to tell them about that there's 3,500, and each of you guys probably has a different spiel, but I usually tell them that there are about 3,500 calories in a pound, and that if you decrease your caloric intake by about 500 calories a day, that ends up being about 3,500 a week. you could lose a pound that way. So from a purely diet standpoint, that's something very quick that I can explain. And then if in the room, when I'm seeing them, if I see that they're drinking soda or something that's unhealthy, or they're eating something unhealthy, then maybe that may give me a clue to sort of talk a little bit about potentially changing diet or what they're eating or what they're drinking, but I may or may not get to that. And then from an exercise standpoint, it may be just around sort of, I may know where they work and then discuss how they could potentially incorporate some exercise in the workplace. So that's sort of, if they come in for related to weight or not related to weight or any other chronic issues, that's usually sort of how much time I'm spending, and the other providers that are in the room, and is that sort of in line with what you? Is that similar? I mean, obviously you may spend a little, your visits may be different in terms of time and duration, but that seems pretty much in line with how I've talked to other sort of primary care providers. So then I was reflecting back. So if I was trying to answer the question, am I successful? Like, how do I know I'm doing a great job? I get, patient experience scores. I may know, my diabetic patients, what their A1Cs may be. I may know if they're hospitalized. So there may be some metrics that our electronic record is able to capture, some metrics that I'm getting from patients, but frankly, I don't know if that really matters to me. So I was sort of thinking and reflecting back, does this really matter? But in our current state, I may not know if I'm successful in my intervention or my counseling until maybe 3 months from now, 6 months, maybe a year, maybe even 2 years, because the only way I'm going to know is when I see that patient again. There may be some cases where I may have some, verbal communication, pointing back to Tosh, I mean, it's great to, she's been with our organization, 15 plus years, and she has a very great relationship with a lot of our patients. So, she sees them out in the community and sort of gives me feedback, but it's very informal. And I get that in terms of if someone is gaining weight, losing weight, we may be able to intervene sooner. But right now, we only find out 3 to 6 months or a year after. So we don't really have a great system to sort of understand if our interventions are working. So I know some of you guys in the room have been involved in some of this, some of the work that we've been doing with the Office of Transformation, along with some of our colleagues from Deloitte and Dynamic, and we've been sort of doing this journey mapping, and essentially what it is really looking at various different touch points when our patients interact with their healthcare system, and what are things that they're doing not only when we're seeing the patients, but then also when they're in the community that impacts their care. So one of the journeys that we had looked at is around diabetes, and sort of had a multidisciplinary group, those that were clinical, non-clinical, really looking at this journey. And this is just you may not be able to see it, and it's more just from a schematic standpoint, but there were sort of 4 different components to that journey, or 4 different broken down sections. So the beginning was sort of building that foundation, so really understanding the different social determinants, really understanding the patient's sort of what could be their ethnic backgrounds and how that may interact and influence their care. Then something can happen, right? So they get sick, they get diagnosed, and then when that happens, they may end up seeking care through the ER, through primary care, through specialty care, through urgent care. So something happens where they're now sort of interacting with the healthcare system. Then once they are given that diagnosis of prediabetes, diabetes, they have to really understand what this new reality is. So what changes or modifications do they have to do to their lifestyle to sort of improve, or to either to keep their diagnosis stable or to improve it so that things don't get worse and they don't develop the complications from having the obesity and diabetes and potentially the heart disease. And then the last step is sort of finding what that new normal is, and really sort of full circle going back to what their new norm may be. And during that, they sort of go through the cycle where they're looking at their diet, their lifestyle, sort of how that influences with their community, their beliefs. And during each of these steps, individuals are sort of interacting not only with us within the healthcare system, but also with our community partners. And how can we understand this journey and impact individuals during these times so that when they get to that next step, we can anticipate their needs and sort of provide the appropriate information, counseling, so that when they do go to the ER or things get worse, that they sort of know that this is going to happen. We sort of can help them, coach and counsel them, and sort of provide them the appropriate education so that things don't continue to worsen and not find out a year from now when they're back in the office. Sort of taking this one step further, these were sort of 4 key themes that came out of some of this journey mapping work, and the other journeys that we looked at, and Dr. Paul was involved as well, was around sort of the OB journey, and as women sort of go through that pregnancy journey, and then if they have a child that ends up being in the NICU, sort of how that journey is, and then also looking at joint replacement. It was the other journey that we were looking at. But some of the key themes that came out of all these different journeys is around bidirectional communication, awareness of available resources, meeting the patient where they are, and that sort of expectation setting. As we sort of hone in on that in terms of our diabetic patients or that population, this is pretty common sense, but this just really puts it into those 4 buckets that I had outlined, but providing sort of that personalized approach, making consumers, customers, or patients aware of the resources that we have, not only within our organization, but with our community partners. Some of that bi-directional flow of information, and that interventions can occur not only just in the walls of the office, but also happen outside, and really trying to eliminate some of that friction during those encounters. And then lastly, sort of looking at some of those social determinants. And I mean, I think we all recognize that it's not just things that happen while they're here, but there's various other elements that influence one's overall care. And then we were able to take it one step further, is that, not only were we able to journey map and then internally figure out what is it that we want to improve, but during sort of this process, we were also able to engage our patients. And in some of that, sort of pointing back to the room back there, through the help of Natasha, we were able to get a few of my patients involved in some of this work in terms of really identifying what is desirable to our customers or our patients as we're understanding how we were looking at this journey. And then, so we not only did focus groups with some of our patients, but then some of the medical assistants and other office staff were involved in some of those discussions, as all of us are patients as well too, in really looking at the desirability of how we're going to be able to move forward. And this was this was the first time I was involved in this sort of methodical, robust approach where we were able to sort of get the inputs from clinical leadership, operational leadership, IT leadership, and the patients, and we were able to sort of look at some of the viability, feasibility, desirability, and really sort of look at those 3 areas and those different stakeholders to really come up with where do we need to really focus, where can technology help, what can we do to sort of eliminate some of that friction and really meet that patient where they are during that journey. So that was a pretty neat exercise. I know there's some people in the room that were involved in some of that work. Would you guys agree that around some of that work that we were able to do, or anything else you guys would like to add? Anyone back there? So now sort of, I think that some of that journey mapping really helped us show where those different touch points are. And then I'd like to sort of end on talking a little bit about different delivery models and how can we sort of learn some of that information from that journey mapping, understanding that the population that we're talking about in terms of the diabetic patients, the pre-diabetics, those that are obese, overweight, a lot of them go through similar journeys. And now that we know that there's different touch points, and we may be able to use virtual care or other means to sort of meet those patients, but how are we going to render care? And we're already doing some of this work, and I think that we just need to really take this time to sort of look at what's been done before, what's evidence-based, and really apply that to the populations we have at hand. So what we'll talk a little bit about is a little bit around group visits, sort of team-based care, and virtual care. So in terms of group visits, I think this has been done for over a century. Our organization has been doing this for quite some time as well. Prior to coming here, while I was at MedStar, I was fortunate to sort of use these sort of 3 different groups. I think the first group was 10 patients, and the next 2 groups that we ran was 14 patients, where we used sort of anywhere between 8 to 10 weeks of 1 to 2 hours of group visits around sort of lifestyle coaching. And these were individuals that were overweight, obese. Some had diabetes, some had pre-diabetes, and it was fascinating to me because we were able to really be out in the community, work with some of our partners. Granted, some of that work was in a more affluent population, and we had good show rates. And from a reimbursement standpoint, the financial guys were happy because I was, more productive in that 1 or 2 hours in group visits versus sort of seeing one-on-one patients. And then I also felt that I was making a difference because we were able to see improvements in weight, BMI, glycemic control, and other parameters over the course of those 3 to 6 months. And then prior to leaving, we also looked to see if that was sustainable, and it was. This is a continuing, evolving program, and I know at Christiana here, and even some of the work that while I was a resident at Wilmington, we were doing group visits. So this is a concept, a model that's been employed here, and it's great for chronic conditions, high utilizers, and we all know sort of the benefits of having some of these group visits. This is just showing that it's been around for over 100 years. The first group visits was used for patients, and as you can see, it's been used for various different service lines, disease states, and all of these studies have shown that group visits has improved outcomes, at least in the short term. And then there have been a few studies looked in terms of systematic reviews to see if this is sustainable. And as you can see, there have been a few of these studies that have shown that there's been lower A1Cs, lower fasting glucose, weight loss over the course of a year, lower blood pressures, and increased knowledge. Yet another study that has shown, another systematic review that's shown improvements that have been statistically significant. ER visits was not statistically significant in this systematic review, but by and large, the various different measures that we look at for diabetes control, and then various different financial metrics around hospitalization, rehospitalizations, and some of the patient-specific quality of life metrics have all shown to be improved in those individuals that engage in some of these group visits. And then there was a randomized trial, randomized control study looking at is this sustainable over time? And some of the results have been promising in terms of lower BMIs, higher HDLs. The hemoglobin A1C, there was no statistical difference between sort of the standard individualized care versus the group visits, but at least some of the other metrics and some of the quality of life, it was sustainable over a course of 5 years. So the next sort of model, and frankly, I think we're already doing a lot of these elements, is more of like the team-based care. So a a lot of the individuals that are in the room, that we all work together in a lot of the patients that we serve between our medical assistants, our nursing colleagues, nutrition, behavioral health. So we're already doing a lot of this, and it's more now how do we sort of formalize some of this work? So essentially, team-based care is just a group of individuals working together, sort of taking responsibility for a cohort or a population of patients. And the reason this is successful is that we're sort of utilizing a multidisciplinary approach, and there's different sort of backgrounds, inputs that each of us is able to sort of impart on our patients, and we're able to sort of provide a more individualized plan for that patient. And since being at Christiana for the last now 6-7 months, it's been great working with some of our diabetic educators, our behavioral health counselors, and in doing some of these co-visits, I'm starting to learn a lot more around some of the social determinants and really how to engage with patients. So not only is this helpful from a patient standpoint, I think it's really also instrumental to sort of really enhance continuing education and knowledge building for the providers, because now, if I have 1 or 2 minutes with the patient, I may know sort of how a behavioral health counselor or a nutritionist may handle certain situations. So, how quickly I can sort of get to what the root of the issue is and provide that appropriate counseling. So I feel like this sort of approach is very helpful, and what we can do with this is really create roles for all the team members, so that not only do we know what their role is while the patients are there in front of us in the office, but then what each of our roles is moving forward, maybe for the next 3 months or 6 months before they come back to the office and to see me in the office. But there may be other touch points as we sort of went through that journey, and now how can we use our existing resources and the individuals that are in our office along with the individuals out in the community, and look at each of those touch points and see where we can sort of add value to that patient during that journey, and if things do deteriorate, what they need to do, and then also provide sort of that positive reinforcement, so that if I saw someone, that we saw someone today, and recognize that the goal is over the next 2 to 3 months to lose 10 pounds, along with being able to do more steps, and then also sort of change their diet. We have that sort of continued dialogue back and forth, and it may not be us calling them every single day or every week, but there may be some things that through technology, through utilizing the care team members, sort of our electronic record, and creating the individualized plan, we'll be able to sort of have that relationship, and that now that we have that strong relationship, sort of the patient and the provider and the care team can sort of have that very seamless bidirectional communication. And so now sort of going back to sort of what does this mean for diabetes? And many of you guys are aware, sort of the CDC over 10 years ago published sort of a landmark study in the New England Journal talking about the diabetes prevention program. So this has been done for many years. The initial was done sort of in person through the YMCA, structured, sort of team-based, along with sort of group visits, going through sort of various different modules and providing sort of structured lifestyle change programs. And we know from earlier in the slide I had mentioned improved exercise and diet in those that have prediabetes leads to over 50% not developing diabetes, or a decrease in 50%. So this is sort of where that statistic came from. And we know that there is even a higher proportion of individuals that are above the age of 60, if they go through this program, that they're going to be successful and going from prediabetes to no diabetes, decreasing weight. And it's not that much weight. It's really just 5 to 7%. So if you're someone that is 200 pounds, sort of 5% may just be 10 pounds. So potentially a 10-pound weight loss could lead to not having diabetes and not having some of those long-term complications, consequences as a result of having diabetes. So I think to sort of wrap up and looking at some of these different themes in terms of group visits, some of the virtual care, and then also looking at team-based care, we know that some of these themes can provide more efficient patient education. The current model may be spending 20, 30, 40 minutes every 3 months. Could we now take that 30, 40, 50 minutes that we're seeing every 3 months and sort of distribute that over the course of 3 months? Now that we're providing more of a team-based approach, can we, we may be able to provide an integrated process to support sort of behavioral change and identify some of the stressors. There's an opportunity for the care team to learn from others. And I think the biggest thing, at least for me, is that the sort of the current pace of and recognizing that there's high burnout, not only in all healthcare providers, care team members, is that sort of this change in pace is refreshing. And I'm fortunate that I'm not sort of seeing patients every single day, and that variety of seeing patients, working at the Value Institute, and also sort of overseeing some of the residents at Wilmington provides me sort of a change on a daily basis, and it keeps me refreshed. And I think it's probably one of the elements of hopefully that won't lead me to burnout from clinical care. And I think if we're able to sort of infuse this back into the way we render care, I think most of us will be happier, and this will lead to not only better retention and hopefully lower obesity, overweight rates with our employees, but then also improvement in patient outcomes moving forward. So this is just a fictitious example. So I was just sort of thinking of how the potential future state may look like. This is just one way of doing things. I mean, sort of going back to Tosh again, I know I've called on her a few times, but it was, right now, the way we know how things are going is through social media and text and getting texts from our patients. I know it may not be HIPAA on how they're doing, so I may just ask her we're concerned about Mr. Jones or Mrs. Jones, in terms of their control of their diabetes or their weight, and she may get information about what their weight may be every week or their blood pressures, because she's well connected with these individuals. So, how can we now take this not HIPAA compliant, not really sort of structured way of doing it and sort of putting it into sort of our potential future state of now being more proactive in how we're reaching out. And, I'm hoping to sort of use this and sort of run a pilot. I know a few of you guys that work at our office, one of our nurse supervisors sort of have been having conversations with her for at least a summer, trying to do a weight loss challenge for the office and incorporating some of those elements of team-based care and group visits, where not only are we're gonna have a structured exercise every day, either prior to working and seeing patients from 7:45 to 8, or around lunchtime. A lot of the staff already do walks together, so they're already doing group visits, and they, at 12 o'clock, they're always like, let's go, and at 11 o'clock when they're rooming patients, the main thing they're looking forward to is lunchtime, not to eat food, but to walk together, right? So we're already doing a lot of these elements of group visits, so we're going to continue with some of that group building activities. There's some additional sort of food changes that we're planning on making, and then sort of gamifying it with some of the weight loss challenges. So this is just sort of how can we use the current evidence and sort of apply it to sort of our population, and then hopefully we can then scale that to a larger scale. So before we leave and I take questions, I just want everyone to stand up. We're going to do 10 squats, and then I'll open it up for questions.
I know.
You guys all ready, you guys?
A little slower now.
Right. Let's start. 10, 9, 8, 7, 6, 5,
On the ground.
4, 3, 2, 1.
He was like, I want to work out.
What's up?
No way.
The next version of this talk, we're going to be doing push-ups, and sit-ups, and a couple other things.
Yeah, where's the burpees thing?
Questions or comments?
So, when you talked about the journey and the and all the stakeholders that you were making, did it result into a suggestion of HRs and changing the way with alerts or sending messages to patients from HR?
Yes, so those on the line, the question is, during some of the journey mapping work, was there discussions on how we can optimize or sort of adjust the electronic record to sort of meet some of those goals? So I think there's ongoing conversations, discussions of how can we utilize our current electronic record, or are there additions that we can use to the EHR so that we're able to sort of improve some of those things. So I mean, I think right now it's rather difficult to do, and oftentimes we're looking at sort of another either tool, vendor, client to sort of have that interface. And I think overall, obviously we have some of the folks that were from endocrine and metabolic health, and right now we're still in that transition period where sort of half of the care team members are using a different electronic record than the other. So I think at least for the next year to two, it may be difficult because we're sort of focusing more of our efforts to sort of consolidating our EHR. And I suspect over the next year or two, we're using sort of other vendors with the hopes that some of these other vendors or tools, so Fitbit, Bluetooth scales, some of the different Bluetooth glycemic control can sort of interface with the EHR. But I mean, right now it's sort of very fragmented. I mean, I guess out of even the different glucose monitors and meters that you guys have, I suspect it's all, you just get it back as a PDF, and it's not very, it doesn't sort of interdigitate within the EHR, right?
It's scanned.
I wish I had a solution.
I'm a wellness nurse at one of the primary care limestone,
Yeah.
actually. So it's a fairly new position. So we see Medicare patients, the nurse-driven program.
Yeah.
We see all the Medicare patients for the annual wellness visit. And I can tell you just from the patients I've seen so far, they all seem to really find it beneficial and valuable because they get a lot of education, a lot of information they can't get in a physician visit. So I'm wondering if it would be kind of an idea to take that model and maybe tweak it or modify it to fit some of these high-risk individuals to maybe a nurse-driven coaching program or coordination of care, something like that.
Yeah, and so one of your counterparts, Megan Ferguson, who works at the healthcare center, I've had conversations with her and her sort of leadership team on how can we sort of use a very similar model and skill set and then apply it to potentially different population, or it could be the same population. Either it could be during sort of that visit, or now that you're already building that relationship, is there an opportunity to sort of do group visits with, and maybe the first step could be Medicare patients that are overweight or obese. And I think the value add for the organization is that now that you're seeing them for a longer period of time, you're building that relationship and that trust, and that differentiates us from sort of virtual provider or app or something like that. So now that you built that relationship, is there an opportunity, a afternoon, and many of these patients may be retired, so can we find a time for these individuals to sort of come in and then learn from each other? And so I think there may be an opportunity to start with that population and then hopefully sort of scale it to other populations that may be high risk.
A great talk. Have you had any conversations or any thoughts about like a stepped care approach model, so that you follow patients as you follow them longitudinally,
Mm-hmm.
and if you see improvements or you see worsening, that you adjust treatment or care appropriately as needed?
Yeah, so I mean there are a few apps and other sort of devices that are out there where you could set certain thresholds. Where, let's just say you set the threshold at 8,000 to 12,000 steps, if I'm using steps as an example, or weight, and if they're consistently below, there's sort of push notifications or sort of alerts to sort of change, sort of see like what's going on, so that we're a little bit more proactive. And you can do that same thing for glucose control, because right now, you may get what their overall average is, or you may get their 3-month average, but you may not really get sort of that daily variation or that weekly variation, and some of that.
An average, you're not
Say that one more time.
it's just a general average. You're not seeing like a percentage
Right.
from a previous time point.
Right. And you can even use like weight, for instance. So if someone is 200 and then they go up to 210 or 205 and whatever threshold you set, 5%, 10% weight increase, that can, I mean, the ideal world, I would get a push notification on those individuals that go up 5%. And if you had a tiered approach where you had 4 or 5 different people on your care team, and if it's a 5% increase, it could be, the intervention could be a call from the medical assistant or the nurse or whatever it may be, based on sort of how the patient wants feedback. So if it's call versus text or email or something like that. So if we already know how the patient wants information, how they best learn, and then once we get input for some sort of variation or change that either is positive or negative, then provide that. So I mean, I think that would be the ideal, right? But right now, you have, that may be going on through whatever device you have. You may have, some of these individuals may have 4 different devices. So one that may be just checking their weight because they have heart failure, one that maybe just calculates their steps, one that's checking their blood sugar, and then their last could be, their electronic record where it's checking their, A1C or other parameters. So in the ideal sense, how can we take those 4 different sort of devices, information, put it together so that we have one dashboard on the patient that's meaningful information that everyone on the care team can look at? I mean, it's a pretty lofty goal.
Yeah.
Right. And if we do that, I mean, that's if you look at some of the top performing countries, I mean, I think it's a little bit easier for them. Some of it because of genetic history or family history, and some of it is sort of one single electronic record. Makes it a little bit easier, but